Hi, my name is Kate McConnell. I am a family nurse practitioner student with the University of Texas Arlington. This is Mr. Lewin McConnell, who will be my patient today. So the first thing I'm going to do is I'll wash my hands, and then we'll get started. Okay. How are you today?
Fine.
Okay. Can you tell me your first and last name?
Lewin McConnell.
And tell me your the date today?
10/17/2017.
Okay. And where are you right now?
Doctor's office.
Mr. McConnell is an adult male. He appears to be well dressed and well groomed for the occasion. He is alert and oriented. How would you identify your mood right now?
Fine.
Patient states that he is in a pleasant mood, and that is congruent with his affect. Next thing I would do is move on to a full body skin assessment. The patient's skin is grossly intact. There is no evidence of any edema or lesions or wounds. There is a small tattoo posteriorly between the scapula as well as a small birthmark. And there's also an additional tattoo on the right side of the patient. Okay. Next, I would move to the hair. The patient's hair is evenly distributed throughout the scalp. It is brown. There is no evidence of any thinning or balding. No evidence of any infestations. And then next I would just go ahead and palpate. The hair is thick. It is not dry or brittle. There's no flakiness. Palpating the scalp. Is there any tenderness there?
No.
The scalp is non-tender. There are no obvious lesions or wounds. Moving down to the head. The head is normocephalic. It is round and midline. The facial features are symmetric. The eyes are, the eyelids are equal. There is no drooping or ptosis noted. The irises are white. The scleras are white. The irises are blue bilaterally. Pupils are round and equal. And the conjunctiva is clear and pink and moist. And close your eyes. The eyeballs are firm, and the lacrimal apparatus is soft and without exudate. Next, I would do a series of vision tests. The first one being the Rosenbaum exam. This exam tests the patient's near visual acuity. So if you'll hold that for me for just one moment. I will measure 14 inches from the patient's face. And then if you will cover one eye and read for me the smallest line possible.
9, 3, 7, 8, 2, 6.
Okay, and if covering the opposite eye.
9, 3, 7, 8, 2, 6.
And then again with both eyes.
9, 3, 7, 8, 2, 6.
Today the patient's near visual acuity is 20/25 with corrective lenses. Another visual screening test tool is the Snellen chart. The patient would, for that test, stand 20 feet from the chart, and again, by covering one eye, read the smallest line possible, switching to the opposite eye, read the smallest line possible, and then again with both eyes, reading the smallest line possible. Next, I will test the corneal light reflex. If you'll just look at a light, point there in the distance for me. I'm just going to shine the light at the bridge of the nose, noting that the light does shine equally in each pupil. Then we'll do the cover-uncover test. Again, looking there at the point on the wall in the distance, I'm going to cover one eye. Noting the patient is without strabismus. And again on the other side. Also noting no strabismus on this side either. Next, I would test the direct and consensual pupil constriction by shining the light in one eye. I will note pupil constriction, and the opposite eye should constrict indirectly as well. So starting on the patient's left side, you'll just look at both pupils constricted. Pupil constriction also noted in both eyes, both directly and indirectly. Next, I would have you do the 6 cardinal fields. So you'll follow my pen light with just your eyes, okay? And try not to move your head. Patient was able to correctly follow in all 6 cardinal fields without any nystagmus noted. And now I will move to the ophthalmoscope exam. First noting with my right eye to the patient's right eye, moving in to find the red reflex, moving in closer, noting that the optic disc is round, the edges are well defined and sharp, and there is no bleeding noted or hemorrhages noted in the optic vessels. Then on the patient's left side with my left eye, noting the red reflex and then moving closer. Again, the optic disc is round, the edges are well defined and sharp, and there is no bleeding noted in the vessels of the eye. Now we move on to the ears. The ears are symmetric. They are in line with the outer canthus of the eyes. And palpating the pinna and lobe and bilateral mastoid processes. Any tenderness there?
No.
The ears are without tenderness. There are no nodules or masses noted. And then move on to the otoscope exam. Starting on the patient's right side, I would, with my left hand, pull up and back on the pinna and bracing with the ulnar surface of my right hand. Moving in. First, look at the external canal, which is without drainage or foreign body. The tympanic membrane is intact. It is pearly gray with a cone of light at the 5 o'clock station. Then moving to the patient's left ear, and with my right hand pulling the pinna up and back, with my left hand bracing with the ulnar surface of my hand, moving in to look at the external canal. The external canal is without any drainage or foreign body. The tympanic membrane is pearly gray, intact, and the cone of light is at the 7 o'clock station. So the next thing I'm going to do is perform a couple of hearing tests for you. First thing I'm going to do is the Weber test. So I will strike the tuning fork and place it in the midline of your scalp, and you will let me know if you can hear the sounds better in one ear or the other, or if you hear them the same equally in both ears.
Equally in both.
Okay. The next test will be the whisper test. So I'm going to step behind you, have you cover one ear at a time. I will whisper a word, and if you could repeat that word back to me as you hear it. So covering your right ear.
Ice cream.
Okay. And covering your left.
Apple pie.
The patient was able to correctly identify both words through the whisper test. Moving to the nose. The nose is midline and straight. Take a look inside. You tilt your head back for me just a little bit, bracing with, again, the ulnar surface of my right hand, tipping the tip of the nose up just a little bit. the other side, again bracing with the ulnar surface of my left hand. The patient's bilateral turbinates are pink and moist. There is no drainage, no polyps or lesions noted, and the septum is without perforation. The MAP patient's lips are pink and symmetric. Any tenderness? No nodules or tenderness noted there. We'll take a look inside. Patient's tongue is moist and pink, as is the buccal mucosa, and gums are also pink, and no bleeding or lesions noted. Please say ah. The patient's uvula rises with pronation. The oropharynx is pink and without exudate. The tonsils are 1+. I'm just going to count your teeth. Okay? The patient has 32 pearly white teeth, no dental caries evident. Moving on to the neck. The trachea is midline. There is no signs of thyromegaly. Assess the or palpate the carotid arteries. Pulses are 2+ bilaterally. So to check the thyroid, I will have the patient take a sip of water. Okay, and you hold this water until I ask you to swallow. Turning your head down into the side here. And swallow. Okay, and we'll do that one more time on the other side. Again, turning down this way. Patient's thyroid cartilage moves freely up and down with swallowing. There are no nodules, masses, or tenderness noted to palpation. I then would auscultate both the carotid pulses, carotid arteries, and the thyroid for any bruits using the bell of my stethoscope. There is no brewing noted in the carotid arteries or the thyroid. I would then move down to the chest, observing the patient's respirations. They appear to be even, unlabored. The patient is not in any distress. And then I would count the patient's respirations. So just go ahead and breathe normally for me. Patient's respirations are approximately 18 breaths per minute, again, even and unlabored. And then, so I will go ahead and then percuss the lung pins. would then move to auscultate the lung fields. First, starting at the trachea. Noting bronchial breath sounds, expiration greater than inspiration. Moving to the main bronchus. Bronchovesicular lung sounds, expiration equal to inspiration. And then to the peripheral lung fills. Vesicular breath sounds, inspiration greater than expiration. Big deep breath. Lungs are clear to auscultation in all lung fields. I would then move to the cardiac assessment, again, assessing the chest. There are no thrusts or heaves noted. I would then palpate the precordium. Moving on to auscultating the heart sounds, starting on the second intercostal space of the right sternal border, aortic. S2 is greater than S1. Second intercostal space, left sternal border, pulmonic. S2 is greater than S1. Third intercostal space, left sternal border, Erb's point. S2 is equal to S1. Fourth intercostal space, left sternal border, tricuspid. S1 is greater than S2. Fifth intercostal space, left midclavicular line, mitral. S1 is greater than S2. And I would listen here for a full minute. Patient's heart rate is 76 beats per minute. The rate is regular, rhythm is regular. I would then again auscultate in the same areas, aortic, pulmonic, Erb's point, tricuspid, and mitral, using the bell of my stethoscope to assess for low-pitched sounds such as murmurs or gallops. I used the diagram of my bell to assess for high-pitched sounds such as S1 and S2. And then I'm going to move on to your blood vessels and your pulses, starting the temporal pulse. to the brachial. Radial. Posterior tibial. And dorsalis pedis. Patient's pulses are 2+ bilaterally. And then if you will go ahead and lay down for me, we'll move on to the abdomen. First, inspecting the abdomen is flat, the skin is intact, it moves evenly, the abdomen moves evenly with respirations. I would then move to auscultation. Bowel sounds are normal active in all 4 quadrants as well as the epigastric region. Then percuss for tympani. Patient's abdomen is tympanic in all 4 quadrants as well as the epigastric region. I will then move to percuss for the liver span, starting at the umbilicus, listening for changes from tympany to dullness. With my tape measure, measuring the patient's liver span in centimeters. Patient's liver is 7 centimeters, which is within normal range of the 6 to 12 centimeters. Then percuss for the splenic span. The spleen is, dullness is heard in between the 6th and 10th intercostal space. Moving to light palpation, I will note any tenderness. Anything tender there?
No.
Patient denies any tenderness with light palpation. Moving on to deep palpation, noting any tenderness or masses. Any tenderness there?
No.
Patient's abdomen is non-tender and there are no masses noted. I will then move on to the Murphy's sign. When the patient exhales, I will press deep into the costal margin and have the patient inhale deeply if pain is elicited, and then there is reason to suspect cholecystitis. So exhale for me. And then inhale. Any pain with that?
No.
Murphy's sign is negative, as evidenced by no pain elicited on inspiration. So next we'll move on to musculoskeletal. So if you would stand for me, and I'm going to have you walk to the door and back. Just paying attention to the patient's posture, the hips and shoulders are even, the patient's gait is normal and symmetric. Okay. If you'll stand with your feet together for me and close your eyes. Just standing by in case the patient falls, but the Romberg test is meant to test for balance. Mild swaying is normal. However, if the patient had trouble with balance, they would be knocked off their feet or have excessive swaying. The next thing I want you to do is just bend over to touch your toes. And here we're looking at the spine, looking for any rib humps, any malalignment of the spine. You'll stand up for me. Palpating the spine as the patient stands up. The spine is straight. You can have a seat. So scoliosis screening is negative. Next, we'll move on to range of motion, both active and passive. We'll have the patient perform the active range of motion first in the cervical spine. So if you can flex your neck forward for me and hyperextend back. Touch your ear to your shoulders on both sides. And then turn your head laterally for me. Patient's active range of motion in the cervical spine is intact, or full range of motion. And then I will perform passive range of motion in the cervical spine as well, with flexion, extension, lateral, and rotation. Okay. Next, moving to the shoulders. If you could raise your arms over your head out to the side for me. So abduction, and comes back down. And if you would cross one over each side. Adduction. Okay. With your elbows bent, place your hands on the small of your back. And then again, with your elbows bent, place your hands on the back of your head. Okay. Patient has full range of motion in the shoulders. Next to the elbows, if you will fully extend at the elbow, and then flex, and then rotate. Patient has full range of motion in the elbows. To the wrist, we will flex down, hyperextend, and then internal rotation, external rotation. Patient also has full range of motion in the wrists. You'll lay down for me on your back. Check the range of motion of the hips. So if you put your legs out straight for me, and then one at a time with your legs straight, raise your legs straight up towards the ceiling. Okay, and the other. All right. And then with your legs straight, if you will bring your leg straight out to the side. Okay, and then all the way across the midline. Okay, keeping your leg up. Okay, and the next one out to the side. And then all the way across midline. Perfect. Okay. And if you can bend your knee one at a time for me. Okay. And then let your knee, keep it bent, and then let your knee fall inward. Okay. And then placing your foot on top of your opposite knee, letting your knee fall to the side. Okay. And then again with the other leg, you can straighten this up. Bend your left leg. Okay. Letting your knee fall all the way to the side. Okay, and then inward rotation. Okay. Also, if you roll over on your back for one last hips, you'll fully extend one leg at a time towards the ceiling. Okay. Hyper extension. Okay. And if you can come to a standing position for me. And if you'll take one leg at a time and extend your knee and flex. Okay, and the next one, extension and flexion. So patient has full range of motion of the hips and knees. Have a seat for me. And then with your ankles, dorsiflexion, plantar flexion, internal rotation, external rotation, adduction, abduction. So patient also has full range of motion of the ankles. Moving from the musculoskeletal system to the cranial nerves, Cranial nerve number 2 is the optic nerve, which is intact as evidenced by the Romberg test earlier. Cranial nerve 5 is the trigeminal nerve. The optic nerve is sensory, the trigeminal nerve is sensory motor. And so we'll test that with different sensations. So I'm going to orient you to these sensations. So this is soft, this is dull, and this is sharp. Okay? So close your eyes for me, and then you'll just tell me what sensation you're feeling, okay?
Soft. Sharp. Dull.
Okay, perfect. So cranial nerve 5 is intact. Cranial nerve 7 is the facial nerve, which is also sensory motor. So if you can give me a big smile, puff your cheeks, squint your eyes real tight for me, raise your eyebrows, and then give me a whistle. Patient's cranial nerve number 7 is intact. Cranial nerve 8 is auditory, which is sensory. That cranial nerve is also intact as evidenced by the patient was able to correctly identify or relay the words used in the whisper test earlier. Cranial nerve number 9 is the glossopharyngeal. The patient, it is sensory motor. That nerve is also intact as evidenced by the patient was able to swallow water during the thyroid testing, as well as the uvula was elevated with phonation. Do you have any difficulty determining between salty and sweet?
No.
Okay. Cranial nerve 11 is the accessory nerve. It is motor. So what I'll have you do is I'll have you perform a series of range of motion if you'll just push against the resistance, okay? So just try to take your ear to your shoulder. And your chin to your chest. Okay? And your try to look to the ceiling. So strong contraction noted in the trapezius and sternocleidomastoid muscles. Therefore, the accessory or cranial nerve 11 is intact. Cranial nerve 12 is the hypoglossal. It is motor. So if you could stick your tongue out at me, move it side to side. Okay. Try to touch your tongue to your nose. Okay. Move your tongue to your chin. Okay. And then you'll push your tongue through your cheek and try to push against my resistance. Okay. Cranial nerve 12 is intact as well. Next, we will test some coordination. So the first thing I'll have you do is place your hands on your knees. Okay, and I'm going to have you switch your hands back and forth very quickly with your eyes closed. Okay, so close your eyes and go ahead and begin. And keep going faster. Patient is able to correctly switch hands back and forth. Next, I'll have you put your hands out to your side for me with your index fingers extended. And then, when we get ready to close your eyes, you'll point to your nose with the tip of your finger, alternating arms. Okay, so go ahead and close your eyes and begin. And a little faster. Perfect. All right, patient was able to correctly align his finger to his nose. Next, we will test some sensation with this using the same soft, dull, and sharp. I'm going to have you close your eyes, and I will, if you can pinpoint for me the location and the sensation that you're feeling. Okay?
Sharp left shoulder. Soft right forearm. Dull left foot. Sharp right foot.
Okay, perfect. And then we will test your vibration sensation. So again, I'm going to place the tuning fork in various locations, and if you'll just tell me where you feel the vibration with your eyes closed.
left shoulder, right calf, left foot, right elbow.
And we will move on to your deep tendon reflexes, okay? First, I'm going to start with your tricep. So you'll just fully relax your arm for me. Okay. Just relax. Next would be your brachial. Just relax your arm. Remove brachial radialis. Then down to your patellar. So if you will take your hands and try to concentrate on pulling them apart as hard as you can, okay? And checking your Achilles reflex. And your plantar. Patient's deep tendon reflexes are 2+ bilaterally. And then at this time, I'm going to take just a second to look at my card. I'm going to move back to the neck and assess your lymph nodes. So starting occipital, post-auricular, pre-auricular, tonsillar, submandibular, submental, post-cervical chain, anterior cervical chain, shoulder chain, supraclavicular, and then axillary. Epitrochlear. Any tenderness to those areas?
No.
Patient's lymph nodes are non-palpable and non-tender. His skin elasticity, skin turgor is elastic. Checking the nails are cut short. They are pink, well groomed. The nails are firmly attached to the nail bed. Capillary refill is less than 2 seconds. And if you could put your fingers, each of them together at the nail. No evidence of any clubbing. going to palpate the inside of the mouth. So if you'll just let me know if there's any tenderness. Okay. So palpating the buccal mucosa and gums. Any of that tender? Floor of the mouth. Any tenderness in there? Okay. So no tenderness or nodules or masses noted inside the patient's mouth. I will also at this time perform tactile fremesis. Okay, so I'm going to place the ulnar side of my hand on your chest, both front and back. And as you feel me move my hand, if you'll just repeat the phrase 99 for me.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Thank you. I'm going to look at my card one more time. One last test here. Just palpating the frontal and maxillary sinuses. Any tenderness in those?
No.
Okay. And then if you'll tilt your head back just a little bit, I'm going to transilluminate your sinuses. So open your mouth for me. Close your eyes. I'm going to show you right here on my cheek. These sides first. Tilt your head back for me. Transillumination of the sinuses shows that there's no consolidation or fluid in the maxillary sinuses.